This is, okay, this is perfect. Here you can see this, post-mortem human heart, and this is an adult heart, and we are going to see the gross morphological features, the epicardial aspect, because you know that the human heart, we have the epicardium, we have the endocardium, and we have the myocardium, okay? The epicardium, you can see now that the epicardium corresponds to the visceral layer of the serous pericardium. In this specimen, we have removed the parietal layer of the serous pericardium with the fibrous pericardium. Then this is the area that corresponds to the epicardium. The epicardium is the visceral layer of the serous pericardium. In this specimen also, we have removed the pericardial and epicardial fibrofatty tissue to visualize the arrangement of the subepicardial myocardial fibers and the arrangement of the coronary arteries in relation with the groove of the heart. This is the sternocostal view of the human heart. We have the sternocostal view and we have the inferior view. This is the inferior view, that this is diaphragmatic. This is not posterior view. This is inferior because the human heart, imagine that my left hand is the diaphragm, the human heart is, the position is in this way. Therefore, my right hand corresponds to the diaphragm, and this is the area that corresponds to the diaphragmatic surface of the heart. This is sternocostal surface that is anterior, and this is diaphragmatic surface. Then the only posterior chamber of the heart is the left atrium. Imagine that this is the simulated right anterior oblique projections. This is posterior and this is anterior. All this area correspond to the right ventricle, and this is the right atrium. This is the superior vena cava, and this is the inferior vena cava. Then the right and the left atrium are chambers that are posteriorly located. Being the more posterior chamber, the left atrium and the left ventricle. The left ventricle is not only left, but mainly lateral and posterior. Let's see the groove of the heart. In this specimen, you can see that this is anterior, this is the pulmonary artery. We are going to see that all this area correspond to the infundibulum, the outflow, or the conus. This is the infundibulum of the right ventricle, and this is the aorta. In this section, you can see this is the superior vena cava, this is the aorta, and this is the pulmonary artery. Note that this is like a simulated thoraxis. This is anterior, and this is posterior. And note that the left atrial appendage and the right atrial appendage are anteriorly orientated. This is simulated right anterior oblique projections, and note that this is anteriorly. The appendage of both right and left atrium are anteriorly in relation with the groove of the heart, with the left AV groove and with the right AV groove. In this specimen, you can see that the aorta is centrally located in relation with the posterior right and the left atrium and the pulmonary trunk. The pulmonary trunk is anterior, and note the different orientation of the pulmonary the pulmonary artery and the aorta. This different orientation of the pulmonary artery and aorta is crucial. This crossing orientation is crucial if we want to see how are the axis of the Creuss complex for VT or premature ventricular extravit from this area of the right ventricular outflow tract or the left ventricular outflow tract. And we are going also to see how is the arrangement of the muscle inside the pulmonary artery. Let's go again to the gross morphology. Note that this is the right ventricle and this is the anterior interventricular groove. The anterior interventricular groove, and therefore this is the anterior descending artery. And this is the left main, and this is the circumflex artery, diagonal artery. We are going to see in some specimen that this is the area that corresponds to the left ventricular submit. This is the left AV groove, and note the orientation of the left AV groove, the circumflex artery, and this is the left atrium. Note, in this case, this artery from the circumflex artery surrounding all this area and all this area to the area between the superior vena cava and the right atrial appendage. We are going to see that this area corresponds to the synod nodal regions. In this specimen, as happened in 20% of the specimen, the synod nodal artery arises from the circumflex artery. In most of the specimen, the synod nodal artery arises from the right coronary artery. Let's go again to these regions. Then, this is the anterior interventricular groove. In the human heart, you can see that from a sternocostal view, this is 2/3 correspond to the right ventricle, and 1/3 correspond to the left ventricle from an anterior view. But if we go posteriorly or inferiorly from an attitudinal orientation of the heart, you can see that the diaphragmatic view, we have 50 and 50. We have the left atrium that is not only left but lateral and posterior, and we have the right atrium. And this is the inferior interventricular groove. This is the inferior interventricular groove, and this is the anterior interventricular groove. Well, if we analyze the groove of the heart, we continue with the left AV groove. Look, the pulmonary artery, the left AV groove, and the right AV groove. Focusing in the right AV groove, note how is the anatomic relation of the left atrial appendage with the AV groove. The left atrial appendage is protecting the right coronary artery. You know that the right coronary artery has the origin in the right coronary cusp, and the left coronary artery have in the left coronary, in the right coronary cusp and in the left coronary cusp, because the non-coronary cusp is posteriorly located. This is the posterior and this is anterior. You can see the right coronary artery and note this artery to the infundibulum. These are the conus artery or the infundibular artery. Right coronary artery, right AV groove, and note this artery. This artery through all these border of the heart. This is the right bordered, and this right border is acute bordered. When we compare with this bordered, that you can see, the left bordered is obtuse bordered. This is the obtuse bordered, the left, and the acute bordered. Then the acute bordered, as can be seen here, all this is the acute. These arteries are the acute marginal artery, because this is the acute bordered. And this artery arising from the circumflex artery are the obtuse marginal artery. Then let's go again to see the anterior or sternocostal view, where we can see all this area that correspond to the infundibulum, the conus, and note that we are going to see an apical component of the right ventricle. But we will describe an outlet, inlet, and apical component of the right ventricle, but the apex only belong to the left ventricle. 3 components for the right and the left ventricle, inlet, outlet, and apical, but the apex belongs to the left ventricle. Again, let's go to the right anterior oblique simulated projections, and you can see the right atrial appendage. Note the right atrial appendage. This is the superior vena cava, and this is the area epicardially that correspond to the synod nodal regions. The synod node is epicardially located, and the compact AV node, you know, that is endocardially located. The synod nodal region is in between the right atrial appendage and the superior vena cava. The synod nodal region from superior, you can see that sometimes have an inferior extensions, and we are going to describe some island or some superior and inferior extensions of the synod node. The synod nodal regions have its anatomic relation with the right coronary artery, and in this case, with the synod nodal artery arising from the circumflex artery. And note that the area of the synod nodal regions, here we have a sulcus. This is the sulcus that endocardially we have the terminal crest. The terminal crest, because all this area of the right atrium epicardially correspond to the area of the trabeculated area of the right atrium, that this is the area of the anterior and posterior pectinate muscle. This is the appendage. Endocardially, we are going to see the pectinate muscle when we when I am going to show endocardially the right atrium, and this is the superior and the inferior vena cava. Note in this specimen, again anteriorly, this area. This is the area that corresponds to the transverse sinus of pericardium. Note that we have the transverse sinus of pericardium between the aorta and the right and the left atrium, and the oblique sinus of pericardium, the transverse sinus of pericardium. And note here, all this area epicardially in relation with the transverse sinus of pericardium that correspond to the Bachmann bundle. The Bachmann bundle is the main interatrial connection between the right and the left atrium, connecting the right atrial appendage and connecting the left atrial appendage. The groove, therefore, are the right AV groove, the right AV groove. Here, you can see the left AV groove, the left AV groove. Again, it's anatomic relation with the appendage, the left AV groove, and the inferior AV groove. In this case, the dominant artery is the right coronary artery. You can see the right coronary artery and the inferior descending artery through the inferior diaphragmatic surface in between the right and the left ventricle, the area that corresponds to the inferior interventricular groove. There are one posterior interatrial groove, and we have two interventricular groove, one that is anterior and the second is posterior. Let's go to this specimen. That this is again a post-mortem human heart, just to show in a different specimen the groove and the border. This is the sternocostal view, This is the inferior. This is the inferior. No sé si tenemos mucha luz, ¿no? This is the inferior groove, the inferior interventricular groove, and note here the interatrial groove. This is the interatrial groove, and the posterior or inferior interventricular groove. One interatrial groove. Note that this is the left atrium. You can focus. This is the left atrium. In this case, we have one common trunk for the left pulmonary vein. This is left, this is right superior pulmonary vein, right superior pulmonary vein, right inferior pulmonary vein, and note the superior vena cava. Epicardially, it is crucial to understand the anatomic relation between the superior, right superior pulmonary vein and the superior vena cava. Again, you can see in this case the transverse sign of pericardium. And please note the Bachman bundle here. You can see the Bachman bundle and the leftward extension of the Bachman bundle epicardially. This is the left superior pulmonary vein, common trunk. You can see the two pulmonary vein, but this is the common trunk. And note the leftward extension of the Bachman bundle and its anatomic relation with the left atrial appendage. Let's go again epicardially, and let's see posteriorly the groove of the heart. This is the posterior or inferior interventricular groove. Right coronary artery, right AV groove, left AV groove, and note here this vein. This vein, this is the vein running with the posterior or inferior descending artery. This is the middle cardiac vein. This is the middle cardiac vein. And all this area correspond to the cross of the heart. This is the interatrial groove, right AV groove, left AV groove, and therefore this is the cross of the heart. This is the base of the heart, the growth of the heart. And note that all this area is fibrofatty tissue. This is epicardially located. This is the area that we are going to use the term inferior pyramidal space. If you continue with this area, this is the coronary sinus, and note that this is the great cardiac vein. From the coronary sinus that is here, this is the point of the coronary sinus, to the great cardiac vein, this vein marks the junction between the coronary sinus and the great cardiac vein. And this is the Marshall vein. This vein is running through the epicardial aspect between the left pulmonary vein and the appendage. This is the epicardial aspect of one very important anatomic structure inside the left atrium that we are going to see. That is the ridge. This is the epicardial ridge. If you see this anatomic relation, note that from an epicardial point of view, we have the leftward extension of the Bachmann bundle between the left superior and the left atrial appendage. Endocardially, this area corresponds to the ridge. And note that this is the area of the Marshall vein, the area of the Marshall vein. From an anatomic point of view, therefore, this is a crucial area from an epicardial point of view, because this Marshall vein is surrounded by postganglionic sympathetic fibers and preganglionic parasympathetic fibers and ganglion, parasympathetic ganglion. In our heart, we have only parasympathetic ganglion, but we have postganglionic sympathetic fibers. Therefore, all this area is surrounded by the neurovegetative system in relation with the Bachmann bundle, the left wall of the Bachmann bundle, that are connecting here. You can see connecting all this area. You can see the Bachmann bundle, leftward extension through the superior aspect of the left atrium, and the Bachmann bundle in the inferior aspect of the left atrium. Therefore, the Bachmann bundle surrounds the mouth of the appendage, and the Bachmann bundle connecting the rightward extension of the Bachmann bundle, connecting the superior vena cava and the area of the synod-nodal regions. Bachmann bundle connecting the right atrial appendage and the left atrial appendage through the transverse sign of pericardium, rightward extension of the Bachmann bundle in connection with the synod-nodal regions and endocardially with the terminal crest, and the leftward extension of the Bachmann bundle endocardially have the ridge and in connection with the Marshall vein. Therefore, this is a crucial anatomic relation of the main interatrial connection of our heart, the Bachmann bundle. Let's continue with this specimen just to show you that this is the outlet component, this is the inlet component, and this is the apical component. And you can see the apex that belong to the left ventricle. In this case, we can see the area that corresponds to the left ventricular submit, and the coronary venous system has not been removed epicardially. Note that you can see the main artery, you can see the left coronary artery, and note the anterior descending artery, through the anterior interventricular groove. You can see the circumflex artery. You can see this branch, this diagonal branch, and note here the great cardiac vein and the anterior interventricular vein. Therefore, the base of the left ventricular submit from an epicardial point of view are marked by the great cardiac vein and the anterior interventricular vein containing in the vertex, containing the left coronary artery and containing the non-accessible area, because this is from an epicardial point of view, this is the dangerous area because the anatomic relation with the coronary artery. We will see endocardially how can we approach the left ventricular submit through the coronary venous system, through the different branches of the great cardiac vein and the anterior interventricular vein, septal and diagonal branches. And we will see how is anatomic relation with the appendage. You can see that recording the appendage, we are recording the area of the left ventricular submit, how its anatomic relationship with the right ventricular outflow tract, and how is its anatomic relationship with the area that corresponds to the left ventricular outflow tract. This is the left coronary cusp. You can see that the left coronary cusp here is in anatomic relationship with the muscle of the left ventricular submit. Appendage, left ventricular outflow tract through the left coronary cusp. This is the left main, left. Posteriorly is the the right ventricular outflow tract and the area that corresponds to the coronary venous system. You know that Miguel Valderrábano now are using ethanol infusion for ventricular tachycardia arising from this area of the left ventricular submit. Epicardially, again, let's see in this specimen the anatomic relation between the superior vena cava and the right superior pulmonary vein. Note this connection, this muscular connection here between the right and the left atrium. Note that we have myocardial connection laterally also between both the right and the left atrium that also we are going to see in the different specimen, but it is crucial to know that this is the anterior, sorry, the posterior, that is the unique interatrial groove, but we have connection not only epicardially through the Bachmann bundle, here, Bachmann bundle between right and the left atrium in the transverse sinus, but also, you can see here the Bachmann bundle beautifully, the connection here, the large, but also lateral connection here, muscular lateral connection between the right and the left atrium. Note here the myocardial sleeve. This is the superior vena cava. You can see the myocardial sleeve of the superior vena cava. Note this is muscle extending over the wall of the superior vena cava. Sometimes we need to isolate the superior vena cava because the presence of extrapulmonary vein foci in patients with atrial fibrillations. And also, this is relevant because we can record far field potential from the right superior pulmonary vein and the superior vena cava because this muscular continuity between both veins. You can see the myocardial tissue extending over the wall of the left superior pulmonary vein and the left inferior pulmonary vein, the common trunk in this specimen. Let's go to see when we want to compare this specimen with the endocardial aspect let's use this endocast. In this case, we have removed this has been, it's like to introduce silicone inside the heart, and we have removed the tissue just to visualize the anatomic relationship, the endocardial anatomic relationship. This is the right aortic appendage endocardially. This is the superior and this is the inferior vena cava. Note that this area corresponds to this area. You see this area endocardially. You can see that endocardially we have the trabeculated right atrium, and all this area correspond to the anterior and posterior pectinating muscle. And note the area epicardially that correspond to the terminal crest. This is the sulcus terminalis epicardially, and this is the area where the sinonodal region are. This area of the sinonodal regions, and note the area that correspond to the right AV groove, that endocardially, this area is the vestibule of entrance to the tricuspid valve. Therefore, endocardially, this is the area that we have shown, and here you can see the three components of the ventricle endocardially and from this endocast. This is the outlet component, this is the inlet component, and this is the apical component. The apex belong only to the left ventricle in red, but we have the three components here that you can see here. We have the area that correspond to the infundibulum, this is the infundibulum, this is the pulmonary artery, this is the inlet, the outlet, and the apical component. Outlet, apical component, trabeculated apical component, the inlet, the vestibule, this is the area endocardially that correspond to the right AV groove, surrounding by the right coronary artery, this is the tricuspid valve annulus, the annulus of the tricuspid valve, and this area here, this area that correspond in the area in between the infundibulum or the conus, and the inlet, this is the so-called supraventricular crest. This is not a crest. This is the aorta that is protruding inside the ventricle. The aorta is here. You can see that this is the aorta, and this is the aorta. And this area is the aorta protruding because note the different orientation of the aorta and the pulmonary trunk. This area corresponds to the ventricular outflow tract. The ventricular outflow tract have a common development in terms of muscle. The distal ventricular groove of muscle here, from an embryological point of view, we have the same origin from the muscle of the right and the left ventricular outflow tract. Note the anatomic relation between the pulmonary artery and the aorta. Note that the pulmonary artery is superior in relation with the aorta. And if we want to have connection between the right ventricular outflow tract and the left ventricular outflow tract, we need to be inside the coronary cusp to reach this area. We're going to see some specimen for this issue. But just to show that here in the right ventricle from an endocardial point of view, we have this supraventricular crest between the infundibulum and the conus, and in between the outflow tract and inlet, between the outlet and the inlet. If we go to this view, you can see this is the area that corresponds to the interventricular septum. Interventricular septum, this is the left atrial appendage. You can see the left atrial appendage. This is the left AV groove. But what is the main difference between the left ventricle and the right ventricle? Note that if we go here, this is the left atrium. In this case, also, we have a common ending. You can see that we have a common trunk, a common ending, left superior, left inferior. And note that anatomic relation between right superior and the superior vena cava. Note that are in close anatomic relationship in this case. You can see. What is the main difference? Let's go again. Let's see, and note that we have the mitro-aortic continuity. They are not this area endocardially in between the outlet and the inlet. We have this continuity between the aortic leaflet of the mitral valve and the aorta. This is the mitro-aortic continuity. You can see that this is the aorta, this is the commissure, and this is the continuity. They are not, therefore, infundibulum. They are not conus. We can use the term left ventricular outflow tract, outlet, apical, but the inlet and the outlet are in continuity in the left ventricle when we compare with the outlet and the inlet in the right ventricle. With this initial view from endocardial and epicardial, let's see the AV groove. In this drawing, I'm going to show you a short axis. Okay, this is the pulmonary artery, this is the aorta, this is the mitral valve, this is the tricuspid valve. This is anterior, and this is posterior. Then, if this is the aorta, here we have, this is non-coronary cusp. The non-coronary cusp is posterior. And note that this is anterior and this is posterior. For the pulmonary artery, we have anterior, we have left, and we have right. Some people use adjacent or not adjacent, okay? And this is the orientation of the short axis. This is this view. This is this view, okay? We are going, sorry, this view. That this is anterior and this is posterior. Lem. Si le aprovechas para poner eso mientras, porque da mucha luz, ¿no? Then, this is the anterior in relation with the aorta. Then this is aortic leaflet, and this is mural leaflet. This is septal, this is anterior, and this is lateral. What is crucial to understand in this short axis? Let's see that we have the right coronary artery surrounding the tricuspid valve annulus. When we see the fibrous skeleton of the heart, we can see that we have a through annulus for the tricuspid valve, and we have a through annulus for the mitral valve. However, we are going to see that we have an independent attachment for the aortic and pulmonary valve. For this reason, we use the term virtual annulus. The virtual annulus, in this case, we have the right coronary artery, we have the main, and this is, in this case, we have the circumflex artery, and this is the right coronary artery. Why I am show you this drawing? This drawing just to understand and to have in our mind with a simple scheme, with a simple drawing, that this is anterior and lateral commissure, and this is posterior and medial. And all this leaflet is anterior, but this is adjacent to the aorta. For this reason, this is the area that we know as the mitro-aortic continuity. And this is septal leaflet, anterior and lateral. The circumflex artery, in this case, and we have here the AV nodal artery and the posterior descending artery. This is the AV nodal artery, and this is the inferior descending artery. And when we see the coronary venous system, we have close to the septal leaflet, we have the coronary sinus and the great cardiac vein here, and we are going to have the posterior interventricular vein. Note this area. This is a very interesting area. This area corresponds to the cross of the heart. In this specimen, we are in this part. This is the middle cardiac vein. This is the right coronary artery. And this, we have here the posterior descending artery. And here we have the tricuspid annulus, and this is the mitral annulus. This is the coronary sinus. All this area that you can see here, this is the cross of the heart, and this is this area. Therefore, we have the sinus, the AV nodal artery inside, go to inside, and this is the right. And this anatomic relation, we have the middle cardiac vein, and we have the AV nodal artery. This is the base of the heart. This is the base of the heart. This is the cross, but this is the base, diaphragmatic area. And this area has been used formerly by electrophysiologists as the posteroseptal regions, as posteroseptal region. But in fact, this is not septal region. This is the inferior and paraseptal regions, because the only septum that we are going to see is the fossa ovalis and the membranoseptum, the atrioventricular membranoseptum. Then let's continue with this area of the thoraxis of the inferior paraseptal regions, and note that we have here the mitro-aortic continuity. This is the area that corresponds to the mitro-aortic continuity. This is the mitro-aortic continuity. And the mitro-aortic continuity is connecting here and here, here, and here, the left fibrous trigon, and the right fibrous trigon, the right fibrous trigon. The mitro-aortic continuity connecting the right and the left fibrous trigon. And with the right fibrous trigon, we have here in yellow, this area that corresponds to the membranous septum. This is the membranous septum. Note that the AV nodal artery goes through the membranous septum. And what is the membranous septum? We are going to see in different slides, in different specimens. The membranous septum is the area that corresponds where the His bundle penetrate from the right atrium. And this is the area of the His bundle. The His bundle is the area of the penetrating His bundle. Okay, then what is the fibrous skeleton of the heart? The fibrous skeleton of the heart is the area that corresponds to the annulus of the mitral and tricuspid valve, and the area that corresponds to the mitro-aortic continuity, the left fibrous trigon and the right fibrous trigon. And all these area, the right fibrous trigon and the membranous septum is the central fibrous body of the heart. Therefore, the central fibrous body of the heart is the area of the fibrous skeleton of the heart, and this area is composed by the right fibrous trigon and the right and the membranous septum, and this is the area where the His bundle penetrate in relation with the AV junction. Let's go again to the specimens, and let's see endocardially. Let's see endocardially this specimen. This is the endocardial aspect of the right atrium and the right ventricle, the right chambers. And note here that we have the area that correspond to the sorry, just to avoid the bright. Okay, this is the area that corresponds to the septal leaflet of the tricuspid valve. Septal leaflet of the tricuspid valve. And this is the supraventricular crest. This is the aorta that is protruding into the outlet and the inlet. The right ventricle, outlet, inlet, apical component. Remember that we show this area that corresponds to the aorta, inlet, outlet, and apical component. The three components of the right ventricle, and what are the main anatomic determinants in the area that correspond to the right atrium, the right chambers. The right ventricle, this is the inferior vena cava. This is the orifice of the coronary sinus. And note that this is the Eustachian valve, and this is the Eustachian ridge. And this is the area of the so-called triangle of Koch. Note, if we focus here, that this is the septal leaflet of the tricuspid valve. Remember that we have the septal leaflet of the tricuspid valve in relationship with the orifice of the coronary sinus and in relation with the AV nodal artery and the area of the His. And this is this area. This is the septal leaflet of the tricuspid valve. This is the Tevesian valve. There are some variability in the anatomy of the Tevesian valve, and this is the Eustachian valve, and this is the Eustachian ridge. This area corresponds to the limits of the triangle of Koch. This is an important anatomic regions of the right atrium, the triangle of Koch, because this area is the vestibule of entrance to the tricuspid valve. The components of the right atrium are the vestibule, the appendage, the venous component, and here you can see that this is the fossa ovalis. We are going to see by transillumination the fossa ovalis. Then, if we perform transillumination here, note that we have the area that corresponds to the fossa ovalis. From superior to inferior, you can see the fossa ovalis, and note here the Chiari network. This is the Chiari network. And the Eustachian valve, the Eustachian ridge, and the area that corresponds to the membranous septum. By transillumination here, this is the area of the membranous septum. Let's try by transillumination from here. Just a second. I don't know if you can see by transillumination. Okay. No da mucha luz. Okay, no, it's not. Just a second. Now, no, I have not enough light here. No, I am not able to obtain transillumination in this specimen. I will obtain transillumination in a new specimen. Okay, this is the area where the His bundle penetrate from the compact AV node that is located in this area. This is the area where the compact, and this is the area of the slow pathway ablations. This is the area of the slow, and this is the area of fast pathway in the limits of the triangle of Koch. Note here, this area. This is the pouch. This is the second anatomic region that we are going to see. This is the Eustachian valve. This is the septal leaf of the tricuspid valve. And this is the area that corresponds to the cavo tricuspidismus, the triangle of Koch, and the area that corresponds to the cavo tricuspidismus. This is from anterior to posterior. This is a simulated right anterior oblique projection. And you can see that from anterior to posterior, we have the Eustachian valve and the Eustachian ridge. Sometimes this is very prominent. And we have this pouch. This is like a resource, subtebesian resource, that correspond to the quadrilateral area of the cavo tricuspidismus. Anteriorly, the septal leaf of the tricuspid valve. This is the vestibule. Posteriorly, the Eustachian valve and Eustachian ridge. And you can see containing the terminal ending of the terminal crest. This is the terminal crest. Here you can see the terminal crest endocardially, and the anterior and posterior pectinating muscle. We have removed the area that corresponds to the appendage. You can see the ending of the pectinating muscle into the vestibule of the tricuspid valve in the area that corresponds to the cavo tricuspidismus. Please note this variable area that containing the anterior and posterior pectinating muscle. The pouch, therefore, we have an area that corresponds to the vestibule, sorry, the isthmus correspond to the vestibule, the pouch, the middle area, and posteriorly the Eustachian valve and the Eustachian ridge. But here you can see this is the area, you can see this yellow area, this is the area where the His bundle penetrate. This is the membranous septum, and note that the inferior aspect of the triangle of Koch correspond to the superior limit of the cabotricuspid isthmus. Therefore, the region of the triangle of the region of the fossa ovalis, again, that has been seen here by transillumination. Note the region of the fossa ovale and its anatomic relation with this area, that is the sinus septum, and the area of the triangle of Koch and the area of the cabotricuspid isthmus. This is the more important area that we need to understand, that when we are trying to do transeptal punctions, we have an enlarged, we have the aorta here. Note that this is the transverse sinus. Sometimes if we go anteriorly and superiorly, we can perform the punction in this area. The only septum in the right atrium is the fossa ovalis. And let's go to this. Note that this is, I have the human heart in these positions. Okay, this is the right atrial appendage. This is a simulated right anterior oblique projection. Then this is the appendage. This is the region of the sinus node epicardially, and the anatomic relation of these regions, as can be seen here. This is the area of the appendage, and this is epicardially the region of the sinus node. Note its anatomic relation with the terminal crest. This is the terminal crest. Okay, this is the regions epicardially of the sinus node. Okay, then in this specimen, we are going to open like a book and note that this is the right ventricular outflow tract, and this is the right ventricle. Note this is here. Okay, we have opened the right ventricle, and note that this is the appendage. This is the right atrial appendage, the right atrial appendage, and the region of the sinus node. Again, let's open. Let's open. This is the AV group. Right AV group. Therefore, the right AV group corresponds to this area. This is the tricuspid valve. This is the tricuspid valve, and you can see here the area of the right atrial appendage. In this case, the right atrial appendage. Now the trabeculated right atrial appendage is here. In this specimen, we are not able to see because we have performed a section of the appendage. All this area corresponds to the appendage. This is the area that now we can see in this specimen that it is this is the terminal crest. If you see the terminal crest in this specimen, note that we have a variable anatomy of this pectinated anterior and posterior pectinated muscle. You can see this area ending into the vestibule of the tricuspid valve. This is the septal leaflet of the tricuspid valve, and note here and here the area that correspond to the fossa ovalis. This is the fossa ovalis here by transilluminations, and note that this is the pouch of the cavo tricuspidismus. All this area correspond to the triangle of Koch, and in this case, note here the Eustachian valve and the Eustachian ridge and the Teresian valve. This is the Teresian valve. Note my finger here. This is a pouch. Look, the pouch of the cavo tricuspidismus. And note the anatomic relation between these fossa ovalis with the area that correspond to the supraventricular crest, because in fact, this is not only a crest, this is the aorta. Look my finger inside, in between the inlet and the outlet. Therefore, the fossa ovalis is here. From superior to inferior, we go from superior, we go, boom, jump, and we have a jump. We go with our catheter from here, 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 and this is just to perform transeptal punction. But take into account that all this area correspond to the supraventricular crest, and the aorta is here. This is the aorta. You can see the aorta here. I am pushing the aorta. Note the aorta there, you can see. Therefore, take care when the approach is superior and anterior, because we are very close to the supraventricular crest and we are very close to the aorta. The wide atrium, therefore, what are the main anatomic regions and the main landmark? First, we have been speaking about the triangle of Koch. We have been speaking about the area of the slow pathway ablation. This is the orifice of the coronary sinus. The close, this is an important anatomic landmark, the coronary sinus. The area of the vestibule of the triangle of Koch, that this is the area containing the compact AV node and the inferior extension of the compact AV node, and this is the area of the, let's try in this case, if I am able to, yes, here we can see if we, can we, okay, you can see by transillumination the area of the membranous septum. Note that this is the orifice of the coronary sinus. And note by transillumination, okay, okay, you can see this, you can see even without transillumination, you can see the color of this fibrous tissue. You see that this is connective tissue. This is this area, the membranous septum and the white fibrous triangle. This is this area. Note that this is the septal leaflet tricuspid valve. This is the orifice of the coronary sinus. These are the limits of the triangle of Koch. But in this case, we have the limits of the triangle of Koch. Here, you see that by transillumination, this is the area that corresponds to where the His bundle penetrate, and the compact AV node is here. If the His bundle is here, the compact AV node is here, and this is the inferior extension. Then, the triangle of Koch and the limits of the triangle of Koch, the anatomic relation, this is anterior, this is the septal leaflet, and note the cavo tricuspidismus, note the pouch in anatomic relation, coronary sinus, you see the coronary sinus, the pouch here, and you see the membrane, because if you perform, you can see here. I'm going to illuminate the base of the heart, okay? Probably you know here that this is membrane. You can see by transillumination all this area that correspond to the base of the heart, because here we are going to have this area that is the base of the heart. The base of the heart is the cross of the heart. Therefore, if I have a punction in this area, I'm going out of the heart. This is the base of our heart. Then, let's go again to see the fossa vallis. Note, it's an anatomic relationship anteriorly. You can see this border anteriorly. Usually, this is thicker and this is thinner, anterior and superior, the rim of the fossa vallis. The rim of the fossa vallis, as shown in this specimen, take into account that this area, this is the Eustachian valve and the Eustachian ridge. Therefore, we are very close to the Eustachian ridge and we are very close to the area that corresponds to the supraventricular crest. Triangle of Koch. Triangle of Koch. The cavo tricuspidismus, the fossa ovalis, the region of the sinus node epicardially, and let's see in this specimen the four-chamber view. Let's note that this is the left atrium. This is the left atrium and the right atrium. And note that this is the muscular interventricular septum. The muscular interventricular septum and the area that corresponds to the fossa ovalis. This is the fossa ovalis. You can see in this area, you can see the fossa ovalis. This is the fossa ovalis in four-chamber view. Therefore, this is the only interatrial septum, because superiorly and inferiorly, this is fibrofatty tissue. And you have seen the fossa ovalis in this specimen, for example, here. You have seen the fossa ovalis here. If we go superiorly and if we go inferiorly, of course, we are going to cross to the left atrium. If I go superiorly from here and I go inferiorly, but note this is fibrofatty tissue, and inferiorly and superiorly, as you can see in this specimen, in this also four-chamber view, note that this is left atrium, this is right atrium, and note that we have opened this area. This area is this. Triangle. This is the inferior pyramidal space. This triangle of the inferior pyramidal space contain endo and epicardially fibrofatty tissue and the area of the AV nodal artery. If we go epicardially, note where is my finger. This is the middle cardiac vein. This is the middle cardiac vein. This is, look here and here. You see that this area epicardially is this area. Therefore, we are here. Then, this is not septum. This is the inferior paraseptal regions containing the middle cardiac vein the AV nodal artery, part of the membranous septum, and fibrofatty tissue. This is the inferoparaceptal regions. This is the area that some people use as right posteroseptal or left posteroseptal accessory pathway. This is parahesian region, parahesian accessory pathway, mid-septal region, left and right paraseptal region. Let's go again here, and you can see that this is the inferior paraseptal, and superiorly is the same. You can see superiorly. Superiorly, you have fibrofatty tissue and fibrofatty tissue. Therefore, this is the only septum. The fossa ovalis is this one. This is the only septum. Here is the only septum. Superiorly and inferiorly, this is a disaster. Look all this area. I can continue dissecting this area from superior to here. Then, of course, if I perform transeptal punction here, I'm going from the right to the left, no doubt. But I'm going out of the heart and inside the heart. Therefore, this is an very relevant anatomy determinant that we need to take into account. The through interatrial septum is the fossa ovalis. Superiorly and inferiorly, we have only the info of the right, or the fall between the right and the left atrium, and this is fibrofatty tissue and fibrofatty tissue resulting and impatient that we have with anticoagulation in resulting in tamponade in most of the cases. Therefore, the through interatrial septum, the through fossa ovalis in this case, and its anatomic relation with the inferior pyramidal space and this folding, and its anatomic relationship with the supraventricular crest and the aorta. This is the transverse sign of pericardium. Sometimes we inject contrast here, and if we don't push with the seed, then we are not going to have problem. But it's just to recognize that we have inject contrast in this area and don't continue. Okay, then let's go again to this four-chamber view just to visualize something that is very important. That this is the atrioventricular membranous septum, this area, this membranous septum and this interventricular, because the membranous septum, now we are going to distinguish two septum. One is the septum that correspond to the, sorry, that correspond with the atrioventricular membranous septum and the interventricular membranous septum. This atrio and interventricular membranous septum are shown in this specimen. Let's see here that in contrast with the pulmonary artery and aortic valve, that where the pulmonary artery is superior in relation with the aortic valve, we have the tricuspid valve inferiorly located in relation with the mitral valve. Note that we have an inferior attachment of the septal leaflet in relation with the mitral valve. This is the mitral valve, this is the annulus. Epicardially, this annulus corresponds to the left AV groove, and epicardially, this annulus corresponds with the area where the circumflex artery and the Greek cardiac vein is surrounding. And this is the tricuspid valve annulus, and this is the area where the right coronary artery is surrounding. Then here you can see that this is the right ventricle. Note that the right ventricle, we have shown that the right ventricle is triangular, and the thicker left ventricle, and the two papillary muscles can be seen here. Note here that this is the muscular interventricular septum, the muscular interventricular septum. And here you can see this area that if we focus here, this is connective tissue. This is connective tissue. And if we continue with the muscular interventricular septum, we're going to have the interventricular membranoseptum, the interventricular membranoseptum, and the atrioventricular membranoseptum, the atrioventricular membranoseptum. Both are the area where the His bundle penetrate. If we see here, we can see that this is the orifice of the coronary sinus. Here we have the orifice of the coronary sinus, and this is the area where the His bundle penetrate here. This is the membranoseptum, and this is the septal leaflet of the tricuspid valve. Note that this is the septal leaflet of the tricuspid valve. This is, from this point of view, from the four-chamber view, the area that corresponds to the triangle of Koch. However, we have this section just to show that the His bundle penetrate here, and because this is the area that corresponds to the atrioventricular membranoseptum. From here, we have connection. In blue, this is the coronary sinus. This is the area of the coronary sinus, but we have the atrioventricular membranoseptum connecting the right atrium with the left ventricle. And this is the membranoseptum that you can see here. And let's see in this specimen. Note here beautifully, in this four-chamber view also, muscular interventricular septum, the attachment of the mitral valve, the tricuspid valve, inferiorly the tricuspid valve, the area that corresponds to the triangle of Koch. This is the coronary sinus, okay? And note that this is the area of the atrioventricular membranoseptum. Note here that this is connective tissue, and this is the attachment of the septal leaflet of the tricuspid valve. This is the fibrous continuity between the tricuspid and mitral valve. The fibrous continuity here, and in this area, we have the compact AV node and the His bundle penetrating through the right bundle branch and to the left bundle branch in the subaortic outflow tract for the left bundle branch. Therefore, this is the muscular interventricular septum, the area that corresponds to the mitral and tricuspid continuity. If we go to this drawing, you can see here and this is left atrium interventricular septum. This is the left ventricle. This is the mitral valve, and this is the tricuspid valve. And here in this area, we have the area that corresponds to the His bundle, and all this area here and here, this is the area of continuity between the tricuspid to mitral valve in these four sections is the same that you can see in this specimen. Note that from, and from histological point of view, here we have the compacted node, and this is fibrous tissue. Therefore, let's continue with the area that correspond to the right and the left ventricle. The right and the left ventricle, and finally we will finish with the left atrium. And just a second. Okay, we have for the right ventricle, we have septal leaflet, and we have the supraventricular crest. Note the aorta, and note these main trabeculation. This is the septomarginal trabeculation, and this is the septoparietal trabeculation. When we see, okay, the right ventricle, note that this is the aorta, that this is the area that corresponds to the supraventricular crest, and the main anatomic point that we need to take into account with the presence of here of one trabeculation, that is the septomarginal trabeculation, in continuity with the moderated band, and here we have the septoparietal trabeculation. Therefore, septomarginal trabeculation, septoparietal trabeculation, and the moderated band. And here we have the three papillary muscle. And the three papillary muscle, we know that are septal, anterior, and lateral. Then let's go to the specimen. This is the septomarginal trabeculation. And note epicardially the presence of this septoparietal trabeculation. Note that this is the pulmonary valve, and this is the area that corresponds to the septal papillary muscle. The septal papillary muscle, it is an anatomic relation with the right bundle branch, and this is right bundle branch, and in continuity with the septal marginal trabeculation, that is in continuity with the anterior papillary muscle that we have been the dissection of the anterior papillary muscle in this specimen. We are not able to see the papillary muscle here. But note the complex anatomy of the group of papillary muscle. This is septal. This is septal if we focus. And note that we cannot speak about septal anterior and posterior. We are speaking about group of papillary muscle because we can see the head, we can see the body, and we can see the attachment. And note how are the muscular connection, and note the tendinous cord. Then the complex anatomy of the papillary muscle can be seen here, and we are going also to show this complexity in the left side. Note here how is the complex anatomy in this case. This is the left atrium and the left ventricle. Note again how are these, in this case, are the inferior and posterior. These are one papillary muscle? No. These are group of papillary muscle with tendinous cord through both the aortic and the mural leaflet. From here, you can see the papillary muscle here. Note that we have, this is aortic and this is mural. The left ventricle has been opened like a book. And note how are the attachment of the papillary muscle to the left ventricle. And note this connection in between the papillary muscle. Then let's summarize the both right and the left ventricle before to go to the left atrium. Then for the right ventricle, we have this is okay, and we have the tricuspid valve, and here we have the outlet, the inlet, and the apical component. This is triangular form. This is the aorta, and this is the supraventricular crest. Three components. This is the infundibulum we have seen. This is the conus, and we have distinguished the supraventricular crest and the presence of this septomarginal trabeculation, the attachment of the septomarginal trabeculation, and the moderative band. What happened with the left ventricle? The left ventricle, we have the aorta, and note conus form. And we have, this is sternocostal view, this is anterior and lateral, and this is inferior or diaphragmatic view. We have papillary muscle, and we have papillary muscle with the tendinous cord. What is the main anatomic determinant when we compare the left with the right? The left, this is anterior and lateral, and this is posterior or medial or inferior or diaphragmatic. 2 papillary muscle in the left, 3 papillary muscle in the right, anterior, septal, and inferior. The anterior connecting with the moderative band, and the moderative band, the right bundle branch in relation with the septal leaflet, with the septal papillary muscle, septomarginal, and in relation with the moderative band. Then we are going to see here the his. I'm going to show you some specimen. Then 2 papillary muscle and the mitro-aortic continuity. The mitro-aortic continuity is between the aortic leaflet that is anterior and the area that corresponds with the norm and the right. Then this is the aortic, the mitro-aortic continuity. The septal leaflet of the aortic leaflet of the mitral valve, and this is the left atrium. Then let's see in this specimen. Then the 3 component: inlet, outlet, apical, septomarginal, supraventricular crest, and septoparietal, and apical, the complex arrangement of the papillary muscle. And now let's see in this, again, in this specimen, you can focus. How is the anatomy relation between the area that corresponds to the septal papillary muscle, que es mural, and this is the septomarginal trabeculation, and these are the septoparietal trabeculation. Let's go again now to the left ventricle. This is the left ventricle. Note here that we have open, again, right anterior oblique projections. Now, apex in this position, and I am going to open the left ventricle like a book, okay? Like a book. And here, you are going to see the aortic leaflet of the mitral valve. This is the left atrium. You can see the fossa ovalis here. This is the fossa ovalis. We can, you can see by transillumination the presence of the fossa ovalis in the left atrium. Okay. This is a pocket. Sometimes this is very relevant. You can see the presence of this pocket here. Note here, I can introduce, look the contact with the pocket, okay? Then, this is the left atrium, but note that we can see here the mural leaflet and aortic leaflet. And note that we have group of papillary muscle. Note that this is thicker, the left ventricle is thicker, and you can see the group of papillary muscle. This is crucial. Please note how is the anatomy of this left atrium. The complex anatomy of the left ventricle, depending on the location and this anterior and lateral or posterior or inferior here papillary muscle. These are group of papillary muscle. Note that this is the head, this is the body, and this is the attachment. Note muscular connection between the papillary muscle. Note, and note that the tendinous cord from the inferior or septal or posterior or the phlegmatic group of papillary muscle connecting to the aortic leaflet and to the mural or posterior leaflet. You can see this connecting here and this connecting here. And the same for the left. And here you can see the anterior and lateral. Note the papillary muscle and note the tendinous cord connecting for the mural leaflet. This is the mural leaflet here. This is the commissure. You can see one commissure, and you can see a commissure. This is the mitro-aortic continuity here, because the aorta, we can have the aorta here. If I introduce the finger, this is the aorta. And note the presence of this sparse trabeculation also. And note the complex group of the papillary muscle. Then first is to understand the nomenclature, and second, the attitudinal orientation. This figure shows the attitudinal location because this is sternocostal view. This is anterior and lateral, and this is inferior and medial. Therefore, these papillary muscle are inferior or diaphragmatic, and this is anterior or lateral. And note this complex anatomy of the papillary muscle. Then, in this section, you can see by longitudinal sections, you can see the area that I have shown here. This is longitudinal, and this is longitudinal. Note that this is the aorta, mitral, left atrium, inferior, and anterior. Okay? Note the papillary muscle here and the thicker papillary muscle in relation with the mitral valve. You can see the tendinous cord, and note in these sections the papillary muscle. This is inferior. You can see that this is inferior. This is inferior, and this is anterior and lateral. This is sternocostal view, and this is inferior view. Therefore, this papillary muscle is inferior diaphragmatic. And this is not attitudinal. This is just to show you. This is the attitudinal orientation. Just to show you, then note that we have the three coronary cusp. This is anterior and this is posterior. The non-coronary cusp, the right and the left coronary cusp. Note here in this specimen, note that this is anterior, this is non. And we are going to see this mitral-aortic continuity in these beautiful sections in this case. Then, this is thoraxis. This is this sections. Note that this is anterior and this is posterior. This is the diaphragmatic view. Okay, this is the inferior. This is this area is this area. Then this is the aortic. You can see the aortic leaflet of the mitral valve. This is the mitral valve. This is the appendage. This is the orifice of the appendage. The left-atrial appendage can be seen here. And note that this is the vestibule of entrance to the mitral valve. And this is the mural leaflet, aortic leaflet. And here you can see the septal leaflet. This is the septal. And you can see anterior and you can see posterior leaflet. And note that the aorta can be seen here is the same. You can see the posterior, the right, and the left. The left has been open. Note in this specimen, this is right, this is left. Sorry, this is known, that is posterior, and the left has it open. This is the pulmonary artery. Note the pulmonary artery, the orientation of the pulmonary artery when we compare with the orientation of the aorta, just to understand the anatomic relation between the right ventricular outflow tract and the left ventricular outflow tract. Then, with this in your mind, now let's see here and let's open like a book the aorta. Look, I am going to open. I'm going to open through this direction. I'm going to open like the book, the aorta. Let's go again. Let's see. And now you can see the mitro-aortic continuity. You can see the left ventricular outflow tract. This is the left ventricular outflow tract. Let's go again. I'm going to close again, and let's go here. Inferiorly. This is the right ventricular outflow tract. This is the right ventricular outflow tract. This is the interventricular muscular septum. You can see the coronary artery. And this is the septomarginal trabeculation. And this is septoparietal trabeculation. And here you can see the pulmonary valve. Note the leaflet and the attachment of the leaflet. This is the inferior view. This is the muscular interventricular septum. This is the aortic leaflet of the mitral valve. This is the mural leaflet. Note inferiorly. Then let's see the anatomic relation of this right with the left ventricular outflow tract. This is right and this is left. Let's go again. Let's see the thoraxis. Then if I perform this dissection, let's see again, and you can see the left ventricular outflow tract. And from the left ventricular outflow tract, note that we have this is known, and here you can see that this is, you can see the coronary artery here. This is right, and this is left. You can see the coronary artery here. Okay, this is left. And this is known. Known is posterior. Then you can see the mitro-aortic continuity. Remember this area. Mitro-aortic continuity, left fibrous trigon, right fibrous trigon, and the area of the membranous septum. Let's go to the specimen, and you can see the area that corresponds to the mitro-aortic continuity. This one, this is a commissure. And note here and here that this is the right fibrous trigon, and this is the left fibrous trigon, aortic leaflet of the mitral valve. This is here, we have connective tissue, and inside here, we have muscle incorporated within the sinus. the same that the pulmonary valve. This is the mitral aortic continuity. And here you can see this area that if we go from the right atrium, this is the right, this is the tricuspid valve, this is the coronary sinus here. Therefore, if this is the coronary sinus and this is the septal leaflet of the tricuspid valve, this is the triangle of Koch. This is the area where the His bundle penetrates. And this is the area of the compact AV node. Then, if I perform transillumination here in this area, you can see by transillumination from the right side, you can see the area that corresponds to the membranous septum. This is the area where the His bundle penetrates. And note that the membranous septum is located between the nom and the right. This is nom, sorry. This is nom, and this is right. And the membranous septum, that can be seen in this specimen, note all this area that correspond to the membranous septum and the right fibrous triangle, mitro-aortic continuity. Right and nom. This is the area where His bundle penetrates. If I go again, look my finger. My finger is here. I am in the septal leaflet of the tricuspid valve. And look, I am going to open and look where is my finger, here. Therefore, this is the area where the His bundle penetrates from the atrioventricular membranous septum. This is the area of the penetrating His bundle beautifully in this specimen. Again, let's go to this anatomic relationship. Note that this is the area of the right ventricular outflow tract and the left ventricular outflow tract. Let's see again, and let's see again. Right ventricular outflow tract. This is the pulmonary valve. This is the membranous septomarginal trabeculation. Look this area. If I try to approach this area from the right ventricular outflow tract, look this thicker tissue. I cannot approach from here. If I want to approach the right ventricular outflow tract, note that I need to be inside the right coronary cusp, because inside I am in this area. Therefore, to understand the anatomic relation between the right and the left ventricular outflow tract, we need first to understand how is the attitudinal orientation of both right and left, crossing orientation. How is the level of orientation and the angulation of the subaortic outflow tract and the pulmonary valve in relation with the aortic valve? You can see that this is inferior and this is superior, but also the presence of this muscle. Let's go finally to the left atrium. Let's go to the left atrium endocardially and epicardially. Let's see in this specimen, that the left atrium we have shown the presence of four. Here we have four pulmonary veins. And note the anatomic relation of the left atrium with the left atrial appendage, epicardially with the Bachmann bundle. Note the Bachmann bundle, the leftward extension of the Bachmann bundle. This is the left atrial appendage. And note in this specimen, epicardially, this is the coronary sinus. You can see the coronary sinus. And note here the area that corresponds to the Marshall vein, coronary sinus, and this is the cross of the heart. Posteriorly, you can see that this is the posterior, this is the interatrial group, this is the left atrium, and note the orientation of this epicardial myocardial fibers. In this case, we have the gross morphology. The gross morphology shows the ending of the pulmonary vein. We can see four pulmonary vein ending, four pulmonary vein, but in some cases, we can have, like in this case, we can have three on the right. Note that this specimen shows three pulmonary vein on the right, and note the muscle here extending over the wall of the right superior pulmonary vein. This is the right intermediate and right inferior. We have shown four pulmonary vein, in this case, three on the right, and we have seen in the previous specimen here a common ending for superior and inferior. This variable normal anatomy appear in 30% of the patients. The presence of a common ending, of the presence of additional pulmonary vein, mainly in the right side. Then gross morphology. Epicardially, its anatomic relation with the Bachmann bundle. Look in these sections. This is a beautiful section where you can see the Bachmann bundle, the leftward extension of the Bachmann bundle. Look here. And this is the left atrial appendage and the Bachmann bundle and its anatomic relation with the Marshall vein in the leftward extension of the Marshall vein. If we go to the endocardial aspect in this specimen, you can see the first point is, look that we have a section of the left superior and left inferior pulmonary vein, and you can see that this is the left atrial appendage. This is the main lobe. This is the main lobe of the left atrial appendage, and this is the, in this case, we have three lobes, the main one, two lobes, and you can see endocardially, this is very different to the right atrium. First point, if we see the thickness of the atrial wall, please note, thicker, thinner, thicker, and thinner. Therefore, they are a non-uniform myocardial content of the left atrium, different thickness of the left atrial wall, and different myocardial content of the left atrium. This is easy to see when we introduce a light inside. Note, in this case, the presence of this absence of muscle, for example, here. We have removed the epicardium, but you can see how is this non-uniform myocardial content of the left atrium. Therefore, this is crucial. How are the thickness of the left atrium, and how is this non-uniform myocardial content of the left atrium? You can see in this case, and note the presence also of myocardial crossing fibers from the right to the inferior. You see epicardially the leftward extension of the Bachmann bundle, but no the connection from inferior to superior. Note this myocardial tissue epicardially and this. Okay, then this is an important anatomic determinant from the left atrium. Second, note this area that corresponds to the ridge. This is the ridge. And note here, you can see that this is the landing zone, and this is the area of entrance to the left atrial appendage. This is a ridge between the left superior pulmonary vein and the left inferior and the appendage. And This is the left superior pulmonary vein. Note this ridge. This is a ridge. Let's go again here. This is not a ridge. This is an inflow of the lateral wall of the left atrium from superior to inferior and from anterior to posterior. We can use the term ridge, but in fact, this is an inflow between the left superior pulmonary vein and the left atrial appendage. Note all this muscle. What is this? This is epicardially located Bachmann bundle. This is the Bachmann bundle that we have shown here in this specimen. Note the extension of the Bachmann bundle between the left superior to the appendage. And if we go to, again, to the previous specimen, note the Bachmann bundle, the extension, and this is the main lobe. This is the area that corresponds to the mouth of the appendage. Then, if you see the orifice of the appendage, we can distinguish 4 components in the left atrium. We can distinguish the venous component that in the right atrium is the intercable venous component. We distinguish the vestibule of entrance to the mitral valve or the vestibule of entrance to the tricuspid valve. We distinguish the appendage, the right of the left atrial appendage, and we distinguish the fossa ovalis. Here, the fossa ovalis cannot be seen because this is the left side. And note here the AV groove and the AV groove. This is the mitral valve. Note the mitral valve and the papillary muscle, anterior and posterior. Therefore, the main endocardial aspect that we need to understand in the left atrium is the ridge between the left superior pulmonary vein and the left atrial appendage. If we go continually, just to finish with this specimen, note that in this specimen we can see the left, the superior vena cava. This is the right atrial appendage. This is the inferior vena cava. And you can see the left atrium just to see the muscle. Note here, this is the area that corresponds to the, if we go with the light, the area that corresponds to the sinonodal region, endocardially, we have, endocardially you can see the crest, but this is epicardially, the area that corresponds to, this is the inferior vena cava, this is the superior vena cava. Note the pectinated muscle in the area that corresponds to the right atrial appendage. And now let's go to the left side. This is the Bachmann bundle. Remember, this is the area that corresponds to the Bachmann bundle. Let's introduce this in just to visualize the left side. Okay. We need less. Okay. We have many. We have a wonderful day in Madrid, and we have a wonderful light in my room, and we are not able to see by transillumination well, doesn't matter. We are we can see the fibrous orientation of the left atrium. Let's see it here. Okay, this is right superior vena cava, and first point, note the connection between the superior vena cava here and the connection with the right superior pulmonary vein. You can see myocardial extension here and myocardial extension. Note that we have this myocardial tissue extending over the wall of the left superior and the left inferior pulmonary vein. These are longitudinal fibers that correspond to the so-called septopulmonary bundle. Epicardially, if we need to understand the myocardial content of both right and the left atrium. First point that we have shown before is the connection through the Bachmann bundle between the area that corresponds in between the superior vena cava and the right atrial appendage, the Bachmann bundle. You see, this is anterior, this is superior, and this is posterior, okay? Anteriorly, you can see the Bachmann bundle, circumferential fibers with leftward extension surrounding the left atrial appendage, and the rightward extension between the superior vena cava and the area that corresponds to the sinonodal region, this area sinonodal region. But we have these fibers, these longitudinal fibers extending epicardially over the wall of the right and the left superior pulmonary vein that are the septopulmonary bundle. And finally, epicardially, we have these fibers that are circumferential fibers. Note, crossing fiber between this longitudinal and this circumferential fiber. Then, what are the epicardial content of the muscle of the left atrium? The Bachmann bundle and the septopulmonary bundle. But when we see the endocardial aspect of the left left atrium here, the endocardium has not been removed. This area corresponds to the septoatrial bundle. Therefore, if we see the left atrium, we have epicardially, we have the septopulmonary bundle and the interatrial Bachmann bundle. And endocardially, we have the septoatrial bundle with 3 branches to the left atrial appendage, to the pulmonary vein, and to the fossa ovalis. Septopulmonary, this is not difficult, but this is basic anatomy for electrophysiology, the septopulmonary and septoatrial bundle. Okay, then I think that we have been working during 2 hours, and I think that we have some minutes for some comment or to discuss whatever you would like.
Thank you very much, José. It's the 4th time I'm listening to your presentation, and it is never the same. So thank you very much for the possibility you have to not bother people who are here every year, because we learn every time different things, and you insist on different parts. And I think there's nothing much better than real specimens to understand what are the real sizes of the structure, what are the real connections, anatomical connection between the structures. And what's very impressive for me today is how you explain to us how, well, dangerous it is when we perform transseptal catheterization regarding all the connection and the very critical connection of the fossa ovalis with different anatomical structures. And I was also very impressed by the way you presented the structure of the epicardial and the endocardial wall of the left atrium. So thank you very much again, and of course,
let me show.
Yep.
Yes, let me share with you. Just a second. Look, this is, you are invited to visit this new web page that we have open. Can you see the screen?
Well, yes, we do.
Yes, this is, the name is Cardiac Anatomy Atlas, okay? Here in this Cardiac Anatomy Atlas, you can see different specimen by 3D, okay, you can see image, the atlas, but this is the same specimen that you have seen. You can move the specimen. You can even look the quality, okay? And you can see the terminal crest. You can see the different structures. Know the coronary artery, okay? Please visit this. This is free. This is free. You can download even the mini atlas. You can download image. This is just to like a summary if you want to review the anatomy. For example, we have here. Let me show you this. You have seen this. This is this specimen. This model. This 3D model. Yes, a second. We need some. I don't know if this is the connection. Okay, doesn't matter. This is, with this you can move the specimen. You can have different 3D reconstruction. For example, look. This is the specimen you have seen before.
Do we have access to your comments and explanations?
Yes. Okay. Okay. Then, ¿cómo salgo? Yes. Thank you again. For me, it's a pleasure to share anatomy. You know that I always write in my Twitter, loving cardiac anatomy. I enjoy, and I try to show in different sessions different anatomic aspects of our human heart. In this case, as you emphasize, I think that the ABC of any electrophysiology is to avoid complication, no? And to avoid complication, it's crucial to know the anatomy relation in attitudinal orientation and to know how is the thinner myocardial tissue sometimes and how can is so close the epicardium to our endocardium, you know, then I think it's crucial. Thank you very much.
As cardiologists, we most often talk about ventricles, and what is also very impressive is the way you show the complexity of the anatomy of the atria. Thank you very much again, and I insist it is never the same, so come back every year to this presentation. You will never hear the same thing. Thank you again, José. Have a nice, beautiful day in Spain.
Yes, you have seen that we have some.
Yeah, it's a beautiful day in Bordeaux too.
Enjoy. Thank you.
Soon.
Enjoy everybody of the master. You have probably you have my email. You have the contact of this learning web page. Anything that you need, please contact with me. I am happy to answer any question that you need. Okay.
Thank you very much.
Bye-bye.
Have a nice day. Bye bye, José.